Yes, we can see that. It
Does,
just needs
it works okay, isn't it?
Yes, it's perfect. Thank you.
Yeah, you can see my disclosure, so the slides are moving okay.
Yes.
Yeah, excellent. Okay, so some housekeeping things that probably you have seen this before, and the excellent presentation from James that this is intended for healthcare professionals. Do not take photos or videos. So we'll cover recognition of.
I can see that Craig has restarted recording. Are you happy with this presentation being recorded, or would you like us to continue?
It's absolutely fine to record the presentation.
Brilliant, thank you.
So what we'll cover is about recognition of obesity as a disease, very brief outline of this. We'll speak mainly about tirzepatide, what it is and what is the mechanism of action. We will focus, Mounjaro, tirzepatide is having a very extensive program into people living with obesity. Out of the 5 studies, we'll focus mainly on SURMOUNT-1 and SURMOUNT-5 studies, which is the key studies, and the SURMOUNT-5 is direct comparison with semaglutide 2.4 milligram, the other very effective weight loss medication. And we will focus, which probably is also the most interesting, on safety data and key factors to consider when treating people living with obesity using Mounjaro. So is obesity a disease? I think that all the presentation from James before clearly demonstrates that obesity is a chronic, progressive, and relapsing disease, but actually seems to be, it is treatable. We can see the milestones to consider obesity as a disease over the years. In 1948, we have initially the ICD codes recognizing obesity as a disease, recognized by WHO in 1997. A number of European countries have recognized obesity as a disease. In UK, there is no still formal recognition of and universally acceptance of obesity as a disease. However, in 2019, the Royal College of Physicians put a statement recognizing obesity as a chronic disease. So, and what is a chronic disease or non-communicable disease? Is a disease that needs to be of long duration, and it is the result of combination of genetic, physiological, environmental, and behavioral factors. I think that James covers the majority of this, and he focuses a lot on the physiological elements and the areas into the brain. Brain is the key organ. Usually as doctors, we want to treat diseases based and understand what is the organ, what is the pathophysiology. I would say that brain is a key organ for obesity, okay? And as we say, obesity is actually the causal root, I would say, for multiple metabolic, biomechanical, and psychosocial health consequences. So addressing obesity improves multiple complications for the patient in front of us. The prevalence of overweight and obesity in the UK, around 2/3 of UK adults are classified as people living with overweight or obesity, is pretty much the same, around 60 to 66% between Wales, Northern Ireland, Scotland, and England. And if we're looking specifically for obesity, not overweight and obesity, is around 28%, 26 to 28% of the population are living with BMI more than 30. What causes obesity? Again, I will refer to the previous presentation. It is multifactorial, sociocultural, environmental, epigenetic, genetic factors, physiological, and behavioral. I would say that 40 to 70% of our weight is genetically predisposed, and the rest is through the other factors that we have. And here we'll focus a little more again, as per previous presentation, on the physiology, because this is what we need to understand, that in a lot of cases is the thing that drives behavior. Our thinking about obesity, it is that usually it is a behavioral element that leads to obesity. Actually, a lot of times is physiology driving the behavior. And that physiology, if we address this, we're having more and more effective treatments. And so in order to do, as we said before, the executive function of going and taking the food, which is controlled from the prefrontal cortex, which is into cortical areas of the brain, there are other 2 areas that they're activated before this, which is the hypothalamus and the mesolimbic system. Hypothalamus is the one that controls satiety, appetite, and energy expenditure, and the mesolimbic system is controlling the wanting and the liking of the food. And these are subcortical areas. So the person does not have any control on how hungry he feels or how much reward is taking from the food. And this is a tsunami of signals that we have numerous times a day that drives the movement to take the food. And we live in an environment that the food is easily accessible around us. So people with obesity, we know that they have increased wanting of food and less liking of food. So they require larger amount of food in order to feel the same satisfaction compared to someone who is lean. And James talked about this regulation in appetite hormones, and this becomes worse when people try to lose weight. This is happening because our bodies have not been created to lose weight. When we're losing weight 500 years ago or 600 years ago, it was because of starvation. So it was not because we were trying to lose weight to go to a wedding and look nice. So the body is having very strong compensatory mechanisms against the weight loss. And the weight loss that we need we require in order to see improvements in different complications differs based on the complication that we are going to treat. Usually the more the weight loss, the more is the benefit, and you can see that even 3 to 5% weight loss may help to improve glycemic control or hypertension. But if we really want to improve cardiovascular outcomes, non-alcoholic steatohepatitis, obstructive sleep apnea, and all-cause mortality, we need to target double-digit weight loss, more than 10 and ideally more than 15% weight loss, especially for people with severe obesity. So the landscape of obesity treatments is not a glorious history, the history of diabetes treatments. We have plenty of medications in the past got off the market because of adverse events. And this is because targeting brain as a key organ is not always easy, because a lot of other functions are controlled by the brain. The first medication approved is Orlistat in 1998, and then there was a 17 years until naltrexone, bupropion, and liraglutide, the first GLP-1 coming to the market. And now we have a much more active area there. Semaglutide is the first one medication that achieved double-digit weight loss, and now we reach the area of the double dual agonists with combining gut hormones, GLP-1 and GIP, and tirzepatide is the first approved dual agonist leading up to 15 to 20% weight loss. I will demonstrate to you in the next slides. So as I say, Mounjaro is the first and only licensed dual agonist acting on two incretin receptors, the GLP-1 and the GIP, and has been licensed for people with a BMI more than 30 as weight management treatment, or BMI more than 27 in the presence of at least one weight-related complication, such as hypertension, dyslipidemia, obstructive sleep apnea, cardiovascular disease, prediabetes, or type 2 diabetes. He has also licensed at the same doses for type 2 diabetes, is indicated for treatment of adults with insufficiently controlled type 2 diabetes as adjunct to diet and exercise, as monotherapy when metformin is inappropriate or is not tolerated, or in addition to other medicine products for treatments of diabetes. So it can be at all the spectrum of diabetes management. And how it works similar to other GLP-1 medications in the brain by reducing the food intake, reducing the appetite and food cravings. Also because the GIP activity, it reduces the nausea that the people usually have with GLP-1 treatments. It also improves glycemic control because also GIP as GLP-1 are incretin hormones. That means that increase insulin secretion, decrease glucagon secretion, and improve insulin sensitivity. It delays also the gastric emptying, but this is transient. This happens for approximately 4 weeks after each dose titration. And the GIP effect also seems to have direct effects into the fat and modulates fat utilization. So the SURMOUNT clinical trial program is the clinical trial program for overweight and obesity management. As I told you, it's a very extensive program, and I will focus here looking also at obesity-related complications like the SURMOUNT OSA, but I will focus on SURMOUNT 1 and SURMOUNT 5 in this presentation. So looking at SURMOUNT 1, they have recruited 2,500 participants. 72 weeks on the medication was the primary outcome. They trialed 3 doses of Mounjaro, 5, 10, and 15 milligrams compared to placebo, and primary outcome was more than 5% weight loss and weight change from baseline. So this was a multi-center trial. It was double-blind, placebo-controlled. It took place in 9 countries. Escalation of the dose was every 4 weeks, and you can see the 3 doses that have been trialed versus placebo, and all the participants received a reduced calorie diet and regular physical activity. Participants were more than 18 years old. As we say, we have BMI more than 30 or BMI more than 27 with at least one obesity-related complication, and they have a history of at least one self-reported unsuccessful dietary effort to lose weight. People with type 2 diabetes or type 1 diabetes were excluded from this trial. And as we say, primary endpoint was at 72 weeks. So they were aiming to see whether the high doses of Mounjaro, the 10 or 15 milligram, this was the primary outcome, had an effect on percentage change in weight from baseline, as well as the percentage of participants with weight reduction more than 5% at week 72. And they have multiple key secondary outcomes looking at physical function, at change in weight categorically, as well as change in quality of life and cardiometabolic risk factors. Looking at the frequency of lifestyle counseling, they were seeing the participants' dietitian or nutritionist at week 0, 4, 8, and 12, and every 12 weeks after. It was a light touch dietary intervention. They advised the classic advice about caloric restriction, 500 kilocalorie per day deficit, with a balanced diet, a classic Western diet with carbohydrates 50%, protein 20%, and fat 30% or less. And the advice also to increase physical activity to 150 minutes a week. The mean BMI was 38, mean weight 105 kilograms at baseline, with well-controlled systolic and diastolic blood pressure and well-controlled lipids. The mean age was 45. 67% of participants were females. This matters because it appears, and this was more clear in SURMOUNT 5, that female participants are achieving more weight loss compared to male participants, around 5% more. And so the main limitations of the study was that obviously participants in clinical trials may have a higher commitment to lose weight compared to the general population. As I mentioned, the baseline cardiometabolic risk factors were relatively normal, so we couldn't see probably massive improvements in this. And only a small percentage of participants were in the range of BMI between 27 and 30, and maybe more studies needed for this population. What they found, and this is one of the key slides in terms of efficacy, you can see that even with a 5 milligram, the low dose, they have achieved 16% weight loss. With a high dose of 15 milligram, they have achieved 22.5% weight loss. The control was achieving a 2.4% weight loss. So this is the first medication that reaches actually the target of 20% weight loss. We're approaching the efficacy of some of the bariatric surgeries here. And if we look at the second primary outcome, 96% of the people on the highest dose achieved more than 5% weight loss compared to 27% of the people with placebo. Actually, the placebo did what we expect and what we see again and again in clinical trials, with 3 out of 10 people achieving more than 5% weight loss. And the more interesting findings is when you look at categorical data for more weight loss, because when you have in front of you a patient, usually the aim is not just 5% weight loss, especially for those with BMI more than 35. They're looking for 10-15% weight loss to make a difference in their life. And you can see that 7 to 8 out of 10 were able to achieve more than 15% weight loss with tirzepatide, 10 and 15 milligrams, compared to 6% with placebo. And 5 to 6 out of 10 were able to achieve more than 20% weight loss compared to 1% with placebo.
Demetrius?
Yes?
Sorry, we've just had a comment. If you could just slow down slightly.
Okay, yes, I can
just
do
so
this.
We can better hear you. That would be fabulous. Thank you.
Okay, I will do this. So looking now at the waist circumference, we can see that there is a 20 centimeter reduction with a high dose of 10 and 15 milligrams compared to 3 centimeter reduction with the placebo, which is massive difference in terms of reduction at 72 weeks. And the majority of the people will respond well to the medication from rather early. So here you can see that when they pulled all the people on tirzepatide together and they saw the efficacy at week 20, in just 20 weeks they have achieved 13 kilogram weight loss already compared to 2.7 kilogram weight loss in the control group. That means that probably you will see more than 50 to 60% of the weight that you expect to see in the first 20 weeks compared to the final weight that was at 72 weeks. Now, except of weight loss, we don't just look weight loss for weight loss to people in front of us. We're looking weight loss to improve health and to improve the quality of life, because obesity, similar to all the other chronic diseases, we have two aims: improving or preventing complications related to the disease, and also improving the quality of life of the person in front of us. So it improves the physical function scores and the physical function of the people. It improved the HDL cholesterol and rather impressive reductions in triglycerides, in cardiometabolic risk factors, approximately 25% reduction in triglycerides. Systolic blood pressure, it was improved by 7.2 over 1 millimeter mercury, which, considering how well controlled was the baseline blood pressure for this population, is a rather important finding. And there was also an overall improvement in non-HDL cholesterol compared to placebo. Except of looking at cardiometabolic risk factors, in this study, the SURMOUNT-1, they were looking also at the DEXA findings. This is a scan for body composition. A subgroup of around 255 participants were having a DEXA scan at baseline and at 72 weeks. The main aim of this DEXA scan, the primary objective, was to see whether Mounjaro is superior in terms of percentage change in total body fat mass loss from baseline to week 72. But also they were looking to see the loss of total body fat mass, as well as to assess percentage change in total body lean mass and change in total body lean mass in kilograms. And they will also look as post hoc analysis what is happening with the body visceral fat with Mounjaro versus placebo. So actually they found that 33% of the total fat mass was in 160 people that finally they have for the analysis reduced, compared to 8.2% for people with placebo. There was a 10% reduction in total lean mass compared to 2.6% reduction with placebo, and there was a significant reduction in visceral fat mass, 40% reduction compared to 7.3% with placebo. Actually, to make this simple, because this is rather confusing, for I can say that for every 10 kilograms, 7.5 kilograms were coming from fat mass, 2.5 kilograms were coming from lean mass. So it is 75% of the weight that someone achieves on the medication is coming from fat mass, 25% is coming from lean mass, and there was a preferential loss in visceral fat mass. Now, looking at SURMOUNT-5, this was a study that compared Mounjaro tirzepatide maximum tolerated dose, the two higher dose, 10 or 15 milligrams, compared to semaglutide maximum tolerated dose, the two higher doses, 1.7 or 2.4 milligrams. This study included 751 people, and it was 72 weeks follow-up. So this is the design. So two groups here: Mounjaro maximum tolerated dose versus semaglutide maximum tolerated dose, 72-week phase 3B open label control trial, again conducted in people living with overweight or obesity without type 2 diabetes, and again very similar design with the SURMOUNT-1 otherwise. When we look at the participants, it's pretty much the same criteria as in SURMOUNT-1: age more than 18, BMI more than 30 or more than 27 with at least one weight-related complication, and history of more than one self-reported unsuccessful dietary effort to lose weight. They exclude people with type 1 or type 2 diabetes. And the primary outcome was to demonstrate that Mounjaro is better, is superior to semaglutide maximum tolerated dose for percentage change in body weight from baseline at week 72. Key secondary outcomes was categorical outcomes and to demonstrate superiority of Mounjaro in change in waist circumference. So the baseline characteristics, the BMI was around 39 in both groups, with majority of the people obviously having BMI more than 35, around 2/3 have BMI more than 35. 55 to 57% of the participants were having pre-diabetes at randomization, mean age 45 years old. Again, 2/3 of participants were female, 65%. The main limitation of this trial is that it was not blinded. However, the results and the findings, it was consistent with those that the previous blinded trials would support the generalizability. So what was the outcomes of this trial? Tirzepatide at the maximum tolerated dose, 10 or 15 milligrams, was leading to 21% weight loss versus 15.4% weight loss with semaglutide maximum tolerated dose, and confirming superiority of tirzepatide. And I think this is the most important when we compare these medications. It is about the categorical weight loss for the patient that we have in front of us. And you see that for the 15, 20, and 25%, especially for 20 and 25% weight loss, if you're looking for people with severe obesity, it almost doubles the chances to achieving these targets, okay? So compared to semaglutide maximum tolerated dose. So much more efficacious Mounjaro for these populations in order to achieve this amount of weight loss.
There is a question there. Was there a scan that showed whether there was any loss in bone density over 72 weeks?
No, there is no scan. The DEXA scan that they have performed was about body composition. There was no scan about how much bone density they may lose. One thing that I need to say is that the GIP is the second element of Mounjaro, the second hormone, okay, on top of GLP-1, appears to have protective effects on bone density. However, we have very limited data with GLP-1s, whether they increase risk for fractures or whether they increase the risk for osteoporosis. Other interventions that leads to significant weight loss, such as bariatric surgery, which leads to these amounts, is associated with increased risk of fractures and increased risk of osteoporosis. However, whether this is because in some cases we have calcium abnormalities after bariatric surgery because of small malabsorptive effect, although they are not malabsorptive operations, they can create malabsorption in some elements. And whether this will be the case with GLP-1s will require further investigation and long-term studies. Currently, I can't say that we have strong evidence that GLP-1s are associated with increased fractures. Safety profile. So what we need to think when we give these medications to people is and what we need to explain to them, the most common adverse events is nausea, diarrhea, vomiting, and constipation. Okay, this is, and they have here abdominal pain, but the nausea, diarrhea, vomiting, constipation is the most common that the people will experience. Around 1 in 4, maybe more, will come and tell you this during the titration. So what needs to be done is for these people is if they experience symptoms that they can tolerate, just stay on the dose for a little more, and usually symptoms are settled. And when they feel more comfortable, we can up titrate the dose if required. Or otherwise, if they have vomiting or severe symptoms, that you need to stop for a little the medication for 1 to 2 doses, and then down titrate to the dose that they were previously tolerated better. They can have another one go later on when they feel more comfortable with this. Another one important thing for people with diabetes is hypoglycemia when used with sulfonylurea or insulin. In the trials, those with sulfonylurea, they have to halve the sulfonylurea. for those on insulin, and I'm talking mainly about basal insulin, you need to reduce the dose by 20 to 30%. For prandial insulin, there is no trial that tested how much you reduce. I personally reduce a little more, close to 40%, and this is because GLP-1s works mainly on prandial glucose levels, okay? Now, other adverse events that you need to inform the person in front of you is cholelithiasis and gallbladder-related events, because of the significant weight loss that you see with the medication. Around 3% of the people with 10 and 15 milligrams of tirzepatide experience this over the period of 3 years. And you need always to let them know about the risk of pancreatitis, which actually the percentage is similar between the control and the tirzepatide group, but they should be aware that if they have severe abdominal pain, they should ask for medical assessment. Another one thing is that it delays the gastric emptying. Some reflux may appear, especially in the first period. And this is important also for contraceptives, because people on contraception, oral contraception, because of this delay in gastric emptying, they may be reduced absorption of the contraceptive medication. So for the period that they escalate the medication, and for 4 weeks after each dose escalation, they need to use a second method of contraception. So if someone is on oral contraceptive, we may need to switch to a non-oral contraception for the period that at least we escalate the dose of the medication. Now, what we can do about the most common gastrointestinal adverse events, we can advise to eat smaller portions more frequently, being mindful to stop eating once full, stay hydrated, avoiding high fat or spicy food, and keep this in moderate level, the intake of alcohol and fizzy drinks. There is limited evidence that these things work, but these are the things that usually we would suggest, especially the staying hydrating and the being mindful to stop eating once full. Special warnings about acute pancreatitis. Patients, as I mentioned, should be informed of the symptoms of acute pancreatitis. Should be used with caution in patients with a history of pancreatitis. And if pancreatitis is suspected, Mounjaro should be discontinued, and if the diagnosis is confirmed, then we cannot restart the medication. Regarding hypoglycemia, I think I explained to you how to reduce the insulin dose and how to reduce the sulfonylureas. Regarding the diabetic retinopathy, the medication has been studied mainly in people with non-proliferative diabetic retinopathy. Obviously, if someone undergoing acute current treatment with ophthalmologist, laser therapy, and all this, we will not usually initiate at this time the treatment. We will wait to complete the treatment. But if they have diabetic retinopathy, what usually we're doing is we are initiating the treatment. But if they are R2M0, R2M1, or above, usually they will be under ophthalmologist, and we inform the ophthalmologist that we initiate the person in this treatment, so they can have a more close follow-up. Now, aspiration in association with general anesthesia, this is something that came over the last years. I think the key thing is for your patient to know that he's on GLP-1, and if he undergoes a surgery, needs to inform the anesthetist that he's on this medication, and based on local policy, they will make a decision whether we'll omit the dose or not before the operation. We talk about gastrointestinal adverse events, especially explain if they have vomiting that they need to omit the medication probably until they will settle, so not become very dehydrated. Has not been trialed in people with severe gastrointestinal disease, such as severe gastroparesis, and should be used with caution in this population. About benzyl alcohol, that patients with hepatic or renal impairment should be informed of the potential risk of metabolic acidosis due to accumulation of benzyl alcohol over time. It's something that I actually personally don't tell to my patients because I don't understand what this means, but it is something that it is in the SPC. Patients should be, yes, when they are driving, to avoid hypoglycemia and take the well-known rules about this. So Something that it is important, if they're in medications with narrow therapeutic index, such as warfarin or digoxin, they will need more close monitoring when initiated of Mounjaro because of the delay in gastric emptying. And so, for example, for warfarin, they will need at least every month and every titration to have an INR to be checked and adjusted. For oral contraceptives, what I told you, advise to switch to a non-oral contraceptive method or at the barrier method of contraception at the initiation for 4 weeks and after each dose escalation. Mounjaro should not be used during pregnancy and needs to be stopped 4 weeks before planning for conception. We don't know the effect of Mounjaro on fertility, and it is also something that we are not using during breastfeeding. So doses 2.5, 5, 7.5, 10, 12.5, and 15. This is the escalation every 4 weeks about this. And then usually the person remains on the maximum tolerated dose for the individual. Is a once-weekly injection, can be added to any existing antihyperglycemic medication. Obviously, you do not combine this with DPP-4 inhibitors. The DPP-4 inhibitor needs to be stopped, and you cannot combine with another GLP-1 receptor analog, okay? So in this case, so it's combining with metformin, SGLT2, pioglitazone, and insulin and sulfonylureas. We talk about reduction in sulfonylurea and insulin dose. Does not require dose adjustment based on gender, race, ethnicity, or body weight, and not adjustment for hepatic or renal impairment, including people with end-stage renal disease. The pen has 4 fixed doses. You ask the person to turn the up to the level of 1, and this will give a full dose. It is stored at 2 to 8 degrees in a fridge. Do not freeze. You can keep this also out of the fridge as far as the temperature does not exceed 30 degrees. And after 30 days, the pen needs to be discarded. Administration sites is in the abdomen, at the thighs. I don't usually suggest the upper arms, but it is in the SPC, so they can use this. The injection should be rotated with each dose and can be given at any time of the day. If someone forgets to get exactly at the 7 days the next Mounjaro dose, for example, if he takes here every Sunday, he can administer this as soon as possible within the next 4 days up to Wednesday. If more than 4 days have passed, then he needs to skip the missed dose and continue with the next scheduled dose. And then they can go back to the once-weekly dosing schedule. So in summary, this is the first Mounjaro tirzepatide, the first and only licensed single molecule that activates both GIP and GLP-1 receptors. In SURMOUNT-1, all the doses of Mounjaro, 5, 10, and 15 milligrams, demonstrated sustained, superior, and clinically meaningful weight reduction compared to placebo, with meaningful, even with the 5 milligram of Mounjaro, 90% of the people achieving more than 5% weight loss. In SURMOUNT-5, we saw that the Mounjaro maximum tolerated dose can achieve up to 21% mean body weight reduction compared to 15% with semaglutide maximum tolerated dose. And the most frequently reported adverse events is constipation, nausea, diarrhea, vomiting, and abdominal pain, which the majority of them are mild to moderate in severity and decreased over time. This is the website where you can find resources for healthcare professionals. And this is where we can find prescribing information. I stop sharing now so I can see you.
Thank you, Dimitris. Would you like me to, there are some questions that need answering.
Yeah.
Have you seen them, Dimitris, or would you like me to share?
I can see them now. I just need to take them from the beginning. Give me a second.
Sure.
Thanks. Sorry, was there a scan? Yeah, I think that I saw this. The license of Mounjaro is not the same as the recently locally commissioned criteria for cohort 1 for weight loss, where a diabetic patient already has good diabetes control, and GPs are not commissioned to prescribe Mounjaro for this group in patients just support weight loss who do not meet cohort 1 criteria, and our local diabetes clinic currently rejects all these referrals. Is a tier 3 clinic offering alternative medications options the only option for us in general practice? This whole area is creating so much work and anger for patients, and we're all getting shouted at on a regular basis when patients feel they're being denied NHS-funded effective treatments. How do we stop other secondary care teams promising that their GPs will prescribe NHS Mounjaro to non-cohort 1 patients struggling with obesity? Can we ask them to not promise on behalf of GP practices? Yeah, okay. So that is one of the, I agree, most heated areas in terms of discussion. I need to be clear that for weight loss, we are talking the current rollout and the implementation plan is for people, for the next 1 year, is for people with BMI more than 40 plus 4 obesity-related complications. These 4 obesity-related complications include type 2 diabetes, include obstructive sleep apnea, include hypertension, dyslipidemia, and there are specific criteria for each one of them, or cardiovascular disease. And what is defined as cardiovascular disease is defined peripheral vascular disease, previous ischemic stroke, previous myocardial infarction, or heart failure. So if the person is having 4 out of these 5 criteria, and all the things that I mentioned as cardiovascular disease is one criteria, then it is eligible to get the medication currently in the implementation. Don't forget that this will, the implementation in 2026, it will go BMI more than 40 and 3 out of these 5 complications that I mentioned. So more people next year will become eligible. The type 2 diabetes pathway is the easier to get people into the medications. Now, if we follow the NICE guidance, if they are already on metformin and SGLT2 inhibitor, and they have a BMI more than 35, I think that it is fair to say that we are heading on the direction of GLP-1 treatment, especially if there are other obesity-related complications. I personally look at the person overall. And this is also has to do with the escalation. Now, if you achieve a good glucose control, for example, with tirzepatide 5 milligrams, and still this patient is having severe obstructive sleep apnea and a number of obesity-related complications, and has achieved 7-8% weight loss, I clearly would suggest that you escalate the dose further to achieve the at least 10 to 15% weight loss for the person in front of you. So it is not about looking, I don't think that we're having a medication for first time, actually. We have a medication that can treat both obesity and type 2 diabetes. So you can have a clinic that you address both with a single treatment. And I think that we should take this as an advantage rather than creating complex pathways that through the type 2 diabetes pathway, it needs to be third line treatment. But because of the obesity pathway, we have a BMI 35 plus needs to have BMI more than 40 plus 4 obesity-related complications. What I'm trying actually to say also is that the actual NICE guidelines, which is different from the implementation plan, they are saying that if it is cost effective for NHS if they have BMI more than 35 plus 1 obesity-related complication and obesity. The implementation plan is because we have so many people with meet the criteria, it is around estimated 3 to 4 million, that it is not possible to give to all of them directly, so they try to prioritize people. Clinically, and as doctor, when I see someone that may not have 4 complications in front of me, but it is young in age, 22, 23, and is having, for example, type 2 diabetes and is having also already heart failure, that I have some of these cases in my clinic, I don't see any argument here, especially if I get a specialist opinion, not to prescribe for type 2 diabetes pathway a treatment to help with weight, because this will help this person overall. And a lot of times we need to optimize a number of things for them. We have a tier 3 weight management service locally that does not commission any prescriber there for medication. So they cannot, to my knowledge, currently in the tier 3 weight management service get access to obesity treatments. Alison is hands up. Sorry, Alison, I think you would like to ask.
I think pretty much everybody have their, just because of the numbers on here and the bandwidth, most people have their microphones and camera automatically disabled. If there's questions, can you put them in chat, please? Okay. Yeah, thank you.
Sorry, yeah. So when treating for diabetes, if HbA1c is stable, should we be stopping reducing? No. The key thing, another one very important thing is this medication is lifelong. Obesity is chronic disease, okay? You can, if the patient responds well, definitely you do not stop the medication, okay? If someone is like you are giving to someone an antihypertensive medication, you improve the blood pressure, you drop this to the target, and then you're saying, okay, we achieved the target, let's stop the medication to see what will happen. You know what will happen, the blood pressure will go up. It's the same story with the diabetes, with the obesity management here, okay? So if you stop, and diabetes, if you stop a medication like tirzepatide that suppresses the appetite, helps the people lose weight and maintaining the weight, at the time that you stop the medication, the weight will come back, and this clearly demonstrated in SURMOUNT 4. It was not into the slides. Reducing the dose, I would just keep at the same dose if it works well for them. Now, if for XYZ reason, trial at what dose person can maintain the same benefits in a lower dose, you can try this, but it will take probably more time, and I'm not sure that people will be, with the evidence that we have currently, is about maintaining the same dose. When they are going to be approved for us to at least consider prescribing for weight loss, so many frustrated and angry patients. I don't know when the local guidelines going to be approved. It is something that will be rolled out over the next 3 years in these people with BMI more than 40 plus 4 complications. Then it is going for BMI more than 40 plus 3 complications, 2026-27. Then 2027 going BMI more than 35 plus 4 obesity-related complications. And gradually, the aim is over the next 10 years to be able to have access to people with BMI more than 35 plus 1 obesity-related complication. I don't know that whether we will have any specific local guideline that will be different compared to the national guidelines. I think that your point before about having a weight management service that can prescribe for specific people, especially those with that are waiting an operation and they cannot have the operation because of the weight, or they are awaiting a transplant, or they cannot undergo precancerous or cancerous conditions operations, is very important, but it's obviously not in my hands. I hope that someone can hear from ICD. How quickly after stopping did patients start to regain the weight? Rather quickly. So the evidence from the SURMOUNT 4 is that people, all of them started on tirzepatide, went up to 20% weight loss, and then they randomized them to continue on the medication or switch to placebo. And so it was those that they continue on tirzepatide reach up to 25% weight loss. Those that they switch to placebo, from 20%, 52 weeks down the line, they were on 10% weight loss. So still there was benefit, but they have regained 50% in the first year. We don't know what will happen later on, but I'm pretty sure that they will continue regaining weight, and probably they will be stabilized around 5% weight loss. This is what we know also from the STEP trials with semaglutide. How do we advise patients if they, what are the macronutrient deficiencies? There are no macronutrient deficiencies known, and they have done a rather good look at this into the trials, but they're going to look also in a little more detail. So there is, we do not monitor for macronutrient deficiencies except if the clinical picture suggests of this. We suggest, however, to ensure that they have a balanced diet, the people. So we ensure that they are getting all the necessarily food intake, and that's why there is a wraparound care program around this. How do we advise patients if they can come off these medications? Again, we do not advise them to come off the medications. It is medications to treat a chronic disease. We aim to keep them. This is the evidence that we have now. Now, if we think that we can reduce the dose, there are trials ongoing. So there are trials ongoing to see how to maintain more efficacious this by reducing the dose to 5 milligrams, for example. We don't have yet this data. So what I'm telling you now, compared to what I may tell you in the next 1 year, it may be different. But currently, the evidence is that we maintain the person in the dose that he tolerates in order to continue achieving and maintaining the weight loss. What is the current? Yes, that's what is the evidence. Should be down titrating to come off this. If the person needs to come off and it is not urgent, yes, we can down titrate. There is no any specific advice. As I told you on the clinical trial, the SURMOUNT-4, as well as in the STEP extension, they stop suddenly the medication and they start regaining. There is no evidence, but I'm telling you again, you need to think about this as a chronic disease. Can a patient be denied the prescription for Mounjaro if they have a raised HbA1c but the BMI of around 30? Are we talking about private prescription here or NHS prescription? This person, for NHS, for obesity management, is probably needs to have multiple other complications and does not have a BMI more than 40 for obesity management. If we're talking about a private prescription, this person, if it's having a BMI more than 30 and a raised HbA1c and wants to pay about tirzepatide, this is absolutely fine. For people with diabetes, the diabetes studies for Mounjaro took place in people with BMI more than 25. So this was not diabetes trials. This was not obesity trials. This was diabetes trials. They were looking with primary outcome, the glucose. So if this person wants to buy the Mounjaro privately, I think that there is no one that can tell her if she has BMI 30 and a raised HbA1c not to initiate on this, but not under NHS. Less likely, not for weight management under NHS. Similar line of question. After starting on Mounjaro as meets criteria for diabetes and raised once HbA1c, but BMI remains above 30, can we still titrate up now as now giving for, sorry, someone, Eddie, do you want to speak?
Yeah, it's just that I just wanted to say that the local type 2 diabetes guidelines for Northamptonshire don't have a BMI cutoff for Mounjaro. So NICE would say you need to have a BMI of over 35 if you have type 2 diabetes. Indeed, you need to have taken 3 oral medications before you get an incretin or a GLP-1 GIP. But in our local guidelines that are available on the GP portal, there is no BMI cutoff. But as you say, the lowest BMI in the studies was 25. And you don't have to have had 3 oral medications before you get Mounjaro. So there is a difference between local guidelines and the NICE guidelines. Our local guidelines are a little bit more, they're less restrictive.
Okay, that's good. Although I didn't know this, as I see only people with BMI more than 35, but that is clear and that is fine for clarifying. If you want my opinion on this, if someone is having a BMI 25 to 30, I may consider other treatments before I go to Mounjaro first. But it is case by case, as we discussed, yes. Similar line of question, after starting on Mounjaro, meets criteria for diabetes and raise once BMI, but BMI remains, can we still up titrate as now giving for no diabetes management? That's what I would do, yes. I have a few patients to go up on their doses. I would definitely, this is, you need to know what you're treating there. If you're just treating for weight and there is no hypertension, there is no obstructive sleep apnea and all this, and they have lost at least 10 to 15% weight loss, maybe not too much benefit of going higher. But if they, and depends on also what is the BMI. We are not as good as with diabetes that we know that the target is HbA1c. We're just talking about percentage of reduction here. Now, if the BMI is if we have, for example, someone with BMI of 50 that dropped to BMI of 42 and have an HbA1c of 42, definitely this person will benefit by further titration because of the prevention of complications that will come even with this amount of weight loss. Okay, so it's a case by case, but if you have something to treat or something to prevent here, I would, that's my practice. I'm increasing the dose to the maximum tolerated dose. We will get these questions answered, but perhaps wait until, sorry. Yeah, Melanie, is a pancreatic cyst contraindication to Mounjaro? Not personal. I think that you need to ask a second opinion from the specialist from the diabetes center around your area. I have people with pancreatic cyst on Mounjaro. However, I had got the opinion from the surgical team looking after this person from the pancreatic cyst. It depends also what is the cause. And so, for example, if it is a pancreatitis because of gallstones, the gallbladder has been removed, and we know that it is a pancreatic cyst, because of this, it is not definitely a contraindication to me to give this. There is no any clear association or any suggestion that the medication will lead to pancreatic cancer or anything like this. So I would say, in principle, is no, it's not contraindication. I don't titrate up further if HbA1c target has been achieved. I just explained that I do, and this is because you need to look the whole person. It's not about HbA1c. It is about what other complications you can improve for the person in front of you. So tirzepatide has got license, and this is important to mention about obstructive sleep apnea. Is the only medication that have license about obstructive sleep apnea. We know that improves heart failure with preserved ejection fraction, and we're talking about intensification of treatment, admissions to the hospital, as well as quality of life in terms of mobility. And we know that in phase 2 trials, it improves also non-alcoholic steatohepatitis. So if the person in front of you, and also improves hypertension, dyslipidemia, quality of life, and all this, so that's the reasons why I, except of HbA1c, I titrate to treat obesity if the person in front of me, I have a target to treat. Concern is beginning to arise as we're swapping one eating disorder for another, anorexia. They were so worried when being advised. It needs to be reduced when they reach now normal HbA1c rates and at risk of becoming underweight. One eating disorder for another, anorexia. Type 2 diabetes patients are so worried when being advised. It needs to be reduced when they reach normal HbA1c and is at risk of becoming underweight. No, in terms of where in the trials they stopped the medication, it was when they were they stopped the medication when people are reaching BMI 18. This is too low. They were advised and reinforced support when BMI was 22. I actually, if the person is going more close to BMI 25, I would not escalate and even down titrate in order to be able to keep them in normal weight. But all these people, based on the guidelines, usually will start from higher, 30, 35 at least in NHS. So there is no any evidence that binge eating disorder or anything like this regarding eating disorders is becoming worse on this medication. Actually, this is it may consider that in some of the cases helps these people to remove the food noise that they experience, and there is observational studies demonstrate this. I haven't as yet, but being challenged by patients who will be going through the question. Are there any longer term studies on maintenance with Mounjaro? Yes, but it is not in people with diabetes. It is in people with obesity. It is the SURMOUNT-1, the extended phase. So the study that I presented you, the SURMOUNT-1, the people with pre-diabetes, they follow them up to 3 years. They exactly flat the line. So they start with 20% weight loss and they remain flat up to 20%, 22% weight loss 3 years down the line. The common adverse, the only adverse event that was appearing a little more compared to the year 1 was cholelithiasis. Sorry? Sorry, it was cholelithiasis. So not cholelithiasis, gallbladder-related events, which was 3 to 4%. Can Mounjaro safely be used in type 1 diabetes with raised BMI and high insulin requirements, Rachel? Has not been trialed in people with type 1 diabetes. It is only something that has been real world evidence, and it appears that it is as effective as in people with obesity without type 2 diabetes. Always people with diabetes lose a little less weight. This is important to remember compared to people without diabetes. So it's around 15% the weight loss with high dose in type 2 diabetes, 22% weight loss in people without diabetes. Now, if you have someone that you feel that may be eligible for, is worth a trial of Mounjaro with type 1 diabetes, I would strongly suggest that you speak to the team into the hospital. If we make something like this, we have very specific criteria, and we have to do an MDT decision, because it's not something that has been trialed. So I wouldn't start from primary care going and do anything like this. I would ask for an MDT opinion and support from nurses to minimize risk for diabetic ketoacidosis. Don't forget, this medication can lead to nausea and can lead to hypoglycemia, so we need reduction in the dose of insulin a lot of time, as well as advice and close monitoring about sick day rules, what to do if she's having vomiting and all of this. So don't do this in primary care. Refer this patient to secondary care with the question. There are some I can answer. Yes, that's Andy. Thank you, Eddie. Would you like to read on slides? Okay. I see Mounjaro as long-term medication. If you got someone's cholesterol under control, wouldn't stop the statins. Yes. If HbA1c is good and the weight is stable and there are no significant side effects, I would then want to continue it long-term. I encourage healthy eating and exercise. Yes, exercise always. This is healthy lifestyle. It's not only about weight loss. It's about health, and health on its own has its own benefits. So it's not about the one or the other, Mounjaro or lifestyle. It's both of them. Okay, the trials were using also advice for exercise and lifestyle interventions. We need both of them to ensure that they maintain maximum health, including muscle and bone mass. We would do studies to see here in Leicester, in combination with exercise, what is the benefits in terms of physical function, and we will assess bone health and muscle health. But currently, the suggestion is you are doing Mounjaro plus some lifestyle intervention for your patient. If HbA1c seems too low, I would wean off sugar lowering meds. Would you agree? Yes, the sugar lowering meds, I suspect you mean I will take off my patient from metformin, or I will take off my patient insulin or sulfonylurea. I wouldn't stop an SGLT2 inhibitor because of the very clear benefits in this population. So I would consider as pillars the SGLT2s and the Mounjaro, or and the GLP-1 based therapy. Are we keeping patients on this long term for diabetes control, or would we need to titrate down after a period of time? This is a question that I will be able to answer to you probably in the next 1 year. It is, you titrate, and I would say currently the evidence is we keep at this dose. You can consider down titrating because the question is coming again and again, but it is likely that this person will start regaining. The difference in the cost is very small to me. It is around 30 pounds between the low dose and the high dose under NHS. So I would think about keeping this. The safest thing to me is to keep this long term, except if they have adverse events or they want to down titrate, where you need to find the dose that maintain the benefits without recurrence of complications and significant weight gain. I had a patient denied and GI side effect and ended up admitted and diagnosed with ischemic colitis attributed to Mounjaro. Yes, we denying any GI side effects. Okay, I don't think that necessarily it was that didn't have any GI effects. It may be the I'm not sure what is the mechanism that ischemic colitis is associated with Mounjaro, and yeah, I cannot comment actually on this without further information, but I appreciate that you are saying that there was a case of ischemic colitis attributed to Mounjaro in a patient that was denying any adverse events. I prescribe gastrointestinal adverse events. I prescribe Mounjaro, but the dilemma I have is when HbA1c is below 48, should I be stopping it? We're currently only able to prescribe for diabetes control. You do not stop for sure. As we say, that in the worst case scenario, you drop the dose, but you do not stop this. And if you have an obesity-related complication that still you need to treat, you probably need to up titrate, okay? My concern is all the people who are self-funding Mounjaro who are not getting regular monitoring, dietary and lifestyle advice and will end up needing support by those of us in primary care if they haven't changed their habits while they are on injections, because they will inevitably be the ones who will regain their appetite counts and hence easily regain their excess fat. So the problem with Mounjaro in self-funding is that the price has been tripled over the last months. I think that it went up to £300 for private prescriptions for the highest dose. So it is an issue that people may not be able to continue self-funding, and it is an issue that they may regain weight if they come off the medication. But this is a different discussion. There is in NHS, however, a program for wrap-around care for these people. Whether we can apply this to people that they are self-funding Mounjaro, I don't know. I don't think that this is the case. In the event of someone seizing Mounjaro, is it correct that weight regained after that is in a higher fat to lean mass? That's good, than existed before, so therefore leaving patient less healthy than previously. We have only evidence, and our group actually has published this, what is happening with lifestyle interventions, and it seems that you gain a little more fat actually compared to lean mass. You are correct. But what is happening after Mounjaro is something that we don't actually know what is happening in terms of the body composition and whether you gain more fat compared to lean mass. So I cannot give a definite answer, but some initial data may suggest that this will be the case. Can you please show the screen with QR code for further info again? Eddie, can we share this or the last slide so they can have the information, the people?
Did you want to show the last slide?
Yes. Do I need to share again? Yes. If you can share the last slide, I'm okay. Do you want me to share?
You'll need to share again. Yeah, I don't have it.
Okay, but then I will not be able to read the questions.
Okay.
Okay. What are your thoughts on ladies who, so would you be able to provide this if someone email you, would you be able to provide the QR code for further info?
Yes, I can do that. I've left my email address and, and my phone number in the chat. So
this
if you
is
want
for Dr. Shah, Sailaya Shah asked about this, okay?
Okay, I'll put my details back in the chat.
What are your thoughts on ladies who are on Mounjaro and on HRT? It is difficult to change oral progesterone to IUD for 4 weeks and then getting back on the oral progesterone. Thanks, Res. There is a guideline that Giles sent me kindly from the from the British Menopause Society, I think, looking exactly at this, what to do. I think that if it is not about pregnancy, usually, except if there are very severe symptoms, this probably will be something that they will be able to tolerate for a period of 4 weeks or 6 months, okay? But yes, so I don't think that it is as important, or it is important, but it is not as crucial as in those that they are taking for contraception, oral contraception. I'm happy to try and post into after answering the questions or emailing you, Dr. Suresh, the guidelines so you can see whether any other option is available. I will do this. Are you suggesting GPs and their team should be prescribed outside the current NHS cohort guidance? No, I didn't suggest this for people with obesity. For people with obesity, they need to do BMI more than 40 plus 4 obesity-related complications. And one of them is type 2 diabetes. What I mainly say is that if you have initiated someone on the medication, think about the whole person. Think about whether you need to escalate the dose to the dose that is required. It dependent of HbA1c. And another one key thing is now we have also cardiovascular outcomes for this medication. So people that they are on Mounjaro because of with type 2 diabetes and the previous cardiovascular disease, independent of what they are doing with HbA1c or weight, they should remain on the medication for cardiovascular protection. Okay, this is common sense and evidence here. The thing that I was saying mainly was for people with type 2 diabetes that I would think early about a GLP-1 initiation if they suffer with obesity and if they are already on metformin and an SGLT2. So this would be the way forward. If they refer to my clinic, obviously I make even earlier recommendation for this. We're already working with secondary care colleagues to avoid them directing patients to us. I don't understand if, so I need to ensure that the implementation plan, that tirzepatide is for community prescribing. People with obesity, BMI more than 40, and for obesity-related complications is to be treated in primary care, okay? So you are correct in saying that if they don't have this criteria, they need to be treated, you cannot initiate the medication, but if they meet this criteria, this needs to be initiated by you, by primary care, okay? This needs to be clear. This is Sanji actually that sent this to me. Yeah, okay. May I ask, why did Lilly allow a leftover of the solution once the 4th dose has been given to risk patients, removing the solution to give a 5th dose, reinforcing this information to patients for safety reasons for airshot use only? May I ask, why did Lilly allow a leftover of the solution once the 4th dose has been given to risk patients? Sorry, I don't understand this question. I'm not sure what is.
Dimitri, I think it's because after the 4th dose, there's quite a lot of Mounjaro left in the pen.
Okay.
And some patients might think it's a 5th dose, or some patients might think that they haven't had their 4th dose. What happens is they try and take what they think is the 4th dose, and the pen jams because they've already had it. Does that make sense? So the fact that there's a lot of Mounjaro left in the pen after the fourth dose can be quite confusing. I think it's important to counsel patients and let them know that there'll be Mounjaro left after the 4th dose, and it's not a 5th dose, despite what TikTok says.
Okay, yes, I have no idea about this. Thanks for letting me know.
Yeah.
Sanjay says, locally we have to prescribe as per the new contract for weight loss as the funding has been allocated as per cohorts. I think that this is what we are saying. When does Mounjaro patent end? I think it must be at least 10 years before. Usually it's 10 to 15 years. I can tell you that the liraglutide patent ended this year, which is 10 years after the approval. So probably in 2035. What will come, and you need to be aware of this, Mounjaro is just the beginning. I mean, in the next 2 years, you will have a tsunami of medications for obesity management and diabetes management and non-alcoholic steatohepatitis management. So Mounjaro is a good first attempt before the tsunami arrives. When does Mounjaro patent end? Yes, wraparound care you mentioned. Yes, there is wraparound care. I think that what they did is that they renamed the diabetes prevention program to pretty much wraparound care. There must be a link. Eddie, do you provide the link to primary care about the wraparound care?
No, we don't have that link.
Okay, I'm pretty sure that this will be, there is wraparound care for each prescription. So I need to just find and give this to you because I speak also to another primary care conference and I need to speak about this. Thank you. or maybe Sanjay has the knowledge about where they can find the link about wraparound care. Obviously, I don't give any wraparound care in my clinic. It's pretty clear because it has a role, but it is priorities to get the people on treatment that will help them. Thank you very much for informative. They are diabetic. So I think this relates, if I remember correctly, the question from the patient with BMI more than around 30 with type 2 diabetes. If they have diabetes, Mounjaro is licensed for people with BMI more than 25 and at least more than 25 now. And it came about this, whether there would be eligible, I don't know so well, seems the local guidance. If they are already in 2 other medications, then potentially, as I understand from what Eddie says, they could potentially even get eligible for GLP-1. But I would say this with caution because I'm just not absolutely sure what the local guidance is. I was informed that sustainable lifestyle changes should be advised. However, was also informed that support of this is only central government support. There will be no local support. How this can be addressed? I'm pretty sure this is referred again to the wraparound care, which is, as I understand, the diabetes prevention program reset on this. I'm pretty sure that there will be a link on this that can be provided. It will be light touch. Definitely it will be light touch. It will not be something really heavy or anything like this. Some will want to switch to IUS anyway. Transdermal progesterone via patches is another option, or increasing oral estrogen after its Mounjaro dose increase as per these guidelines. Thanks for this. Joan is in response to previous question from Dr. Mali about Mounjaro on HRT. If a diabetic patient has been purchasing Mounjaro over the counter and on review HbA1c now below 42 and BMI under 30, can we prescribe as now not meeting the criteria? Now, on this, I think that speaking before to Sanjay, it's pretty clear that for obesity, if do not meet the current criteria, BMI more than 40 plus 4 obesity-related complications, independent of if they got this, they took the medication and they went into a lower BMI and before we're meeting the criteria, you cannot prescribe locally for obesity. That's what is my understanding. Also, I disagree with this, but this is what they have told me. For diabetes here, where it is your question, if you have a previous clear understanding that this person was having a high HbA1c and meets the criteria outside the HbA1c 42, if she has type 2 diabetes, I think that I would consider this. I'm happy to have a look at this, or I would be happy to discuss with you about this case because I have similar cases where, based on the individual case, I recommend to reinitiate because if you stop, there will be a deterioration of HbA1c and weight regain. Now below 42 with BMI under 30, as now not meeting the criteria. So, and he also says that we don't have a BMI under 30 for people with type 2 diabetes. So I would consider this. That's what I'm saying. Hi, sorry to ask a similar question again. We have a patient with type 2 diabetes with obesity. He has been on semaglutide and now on Mounjaro for almost 1.5 years. His diabetes has reversed in 3 years, HbA1c less than 30. BMI has dropped from 42 to 34 per patient, is keen to continue injection. Continuing injection is the answer to this. What should be the approach? I think that probably I don't pass very clear the message that if you have someone who dropped from 42 to it's like you have someone with blood pressure 180 that drops to 150, still suboptimal, but much better and much lower risk. There is no point of stopping the antihypertensive that drop the blood pressure to this level, okay? Even if you don't have something better to add here, he should continue on this. The proposed updating NICE guidelines also look to introducing GLP-1s earlier too. That's very correct, but still, and I agree that it is a step forward, but what I think we need is to create a common guideline for obesity and type 2 diabetes, because all the medications that I mentioned for obesity, they are also for type 2 diabetes, and they will come under. So for people with BMI more than 35 and one obesity-related complication, over the next 5 years, GLP-1 should be first line. But this is my opinion. This is the opinion also of the ADA, American Diabetes Association, and the ESD, European Association for the Study of Diabetes. But yes, still with NICE, we have to work a little more. This is because of cost effectiveness. I'm pretty sure that if they judge that for BMI more than 35 plus one obesity-related complication is cost effective for people with obesity, it just makes sense that it is something that should be first line for people with BMI more than 35 and one obesity-related complication, including the people with diabetes. So I think that we need just to join the guidelines, the obesity and the type 2 diabetes guidelines, because we have the same medication providing the same for both indications.
Demetrius,
Yeah.
I think we're running over time.
Sorry. Yes, I didn't.
No, that's fine. I think the questions you're getting show the importance of this and the interest. So thank you very much for a very, very useful presentation. I think Ed has put a suggestion there that if people want to, they can get in touch.
Yeah.
Questions and you'll be happy to interact.
Just put it inside my email, so some of them they may want to ask some questions.
Perfect. Thank you so much. It has been a really, really useful afternoon.
Thank you very much. Bye-bye.
Thank you.
Bye.
And thanks, Eddie, as well.
No worries at all.
Thank you. Okay, I think that is the end. Thank you everybody for staying on, for all the questions, for all of the energy that we've had this afternoon. It's been a really good session, so thank you, and thanks Craig and Mel, although I don't think Mel's here anymore, for supporting this, and I will see everybody soon. Craig, you all right finishing the recording? Are you still here?
Yeah, absolutely. And thanks very much from everybody from us as well. Just want to say thank you for the people that have already filled out the feedback form. We've had some really good feedback so far, and I'll probably release the dashboard that will show the kind of the responses to it and the net satisfaction scores for it, because it's really exceptional. I want to thank all the speakers as well, and look forward to our next PLT, which now won't be until the new year. So from our side, have a fantastic Christmas and all of that. There we go. It's only November and somebody's wished you happy Christmas already. So from our side, take care, look after yourselves, and if you do have any questions, please let us know. In addition to that, I will be sending an email out to everybody who's attended with the link to the feedback form, just in case you haven't been able to get it. And don't forget, fill the feedback form in, you get your certificate. That's kind of the way it works. So once again, thanks to all the speakers and thanks to everybody who supported. And we'll speak again soon.
Thanks very much. Thanks. Bye.